Hi, my name is Rachel Sanders from Avenir Health. I am going to be presenting today on using the OneHealth tool for budgeting for TB. These materials were prepared by myself and by Inez Garcia Baena from the WHO Global TB Program. There will be 5 sessions designed to prepare people to estimate the cost of their TB plan using the OneHealth tool. The first, this one, is going to focus on a general overview of the OneHealth tool. Session 2 will focus in on TB-specific content from that tool, and Session 3 will be an overview of OneHealth tool's special features. Sessions 4 and 5 will focus on the impact models that are available, including time estimates and time impact. The content of this session is, as I just noted, a course overview. We'll discuss the learning objectives and the rationale for using the OneHealth tool. Most of the time will be spent reviewing the structure of the OneHealth tool and the calculation patterns for intervention costing and program costing. Finally, I will talk about how to configure your file and do a short software demonstration. After viewing this session, participants should be able to understand the history and general use recommendations for the OneHealth tool, describe the overall structure of the tool, and understand the basic calculation patterns for intervention and program costing. The OneHealth tool is a UN-sponsored tool, and it's given guidance by the UN Interagency Working Group on Costing. Oversight is provided by that group to ensure technical excellence of the tool and updates as needed. The software is available at the website on your screen, www.avenirhealth.org/software-onehealth.php. Frequent updates are available to update demographic information and epidemiological information and cost data. New versions will overwrite the old version, and the projections that you have developed will work in future versions. There are also manuals available on that site and a link to frequently asked questions and what we call a helpline where you can reach out for support from our team. The OneHealth tool fits squarely within the strategic planning cycle, where one might begin with priority setting using cost effectiveness analysis, then proceed to the strategic planning and budgeting step, and also think about investment cases which demonstrate the economic benefits of investing in different programs. The OneHealth tool will fit within that middle bucket of strategic planning where we look at the cost, the health impact, health systems, and affordability. Typically, the cost effectiveness analysis function is performed using the generalized cost effectiveness analysis function in Spectrum or GCEA, and the economic benefits investment case can be done using EPIC, the economic projections of illness and cost of treatment. This is the general OneHealth tool structure. As you can see, at its core are a number of different health programs, including TB. Within each of those programs, there are a series of interventions which can be delivered at different levels or through different delivery channels, as we call them in the tool. These roll up to give you national level cost for different interventions and health programs. Each of these health programs is underpinned by the health system. The tool follows the health system's building block approach with components for infrastructure, human resources, supply chain, health information systems, governance, and health financing. all of these structures are considered within an envelope of financial affordability, with the end goal of increasing coverage of effective interventions in order to save lives and increase the health of populations. These costing packages are linked to impact models, which include those focused on TB, time estimates, and time impact, which we'll discuss in further detail later in this presentation. This component will give you an overview of the costing methods used in the OneHealth tool. First of all, I should note that the tool takes a public healthcare provider perspective by default, which is to say that it asks what would be the cost to the public sector of providing a given level of services. It uses a basic ingredients-based costing approach, multiplying the price for delivering a service times the quantity of services, P times Q. And there are two approaches to costing a disease or a package of interventions. The first is what we might call a vertical costing, where you focus in on just one disease and try to establish the costs of treating that disease or providing that set of interventions. And the second is what we call a sector-wide approach, which looks at a broad array of health programs set within the health system, where health systems components act as budget holders that support the different health programs. There are two primary components of the costing approach. The first is intervention costing, or the direct service delivery costs. These are linked to epidemiological projections of the number of people needing services and includes labor, inpatient and outpatient visits, and consumables. Again, it's a P times Q, price times quantity, where the price includes consumables, labor, and visits, and Q is the number of services or number of clients receiving the intervention. Program costing is not linked to epidemiological projections, except in the case of TB for lab equipment. And program costing takes an activity-based costing approach, where each activity is costed by looking at the number of activities that you might do and the price per activity. So for example, number of trainings times cost per training. This schematic gives you an overview of costing a disease plan within the OneHealth Tool sector-wide costing approach. You would calculate drug and supply costs for each intervention and program area, but health system costs, including human resources, are calculated by the health system as a whole. So human resources, even for TB, would be accrued under the human resources health system building block. In order to complete this type of costing, you would fill out both the TB program information as well as the relevant health system interventions. So that would include training and staff requirements, equipment, recurrent costs, logistics, and health information systems. If you take the approach of what we call disease-specific costing, then you would fill out intervention costing. Sorry, my screen. If you take what we call a disease-specific costing approach, then you would fill out the intervention costing component, which would calculate the drug and supply costs for each intervention and program area, and would also provide the data that you need to calculate labor and inpatient, outpatient visit costs calculated by intervention. And you would also fill out the program costing component, which incorporates disease-specific information about training, human resources, et cetera, but also incorporates disease-specific information about capital costs and recurrent costs. This schematic gives you a big picture view of how all these different pieces fit together. The costs for the consumables are consistent no matter which approach you take. If you take the health systems or sector-wide approach, then you would cost human resources and infrastructure costs through those building block approaches. If you were to take the disease-specific approach, then you would only calculate the number of visits and patient days and number of minutes for providers, and then that would be calculated as part of your direct TB costs. So this is just to give you some of the background about the different approaches that you might take for costing. And now we're going to focus in on the actual methods and calculation patterns for each. We're going to start with intervention costing. As I mentioned, intervention costing looks at the price per unit times the number of quantities. The inputs for the OneHealth tool to calculate the numbers of services, which is what we equate with the quantity, is the target population times the population in need times the intervention coverage in order to give you a number of services. Those services are then distributed across all the different delivery channels in order to give you a number of services at each level. The inputs for the OneHealth tool to calculate price include drugs and supplies, personnel time, and inpatient days and outpatient visits. The first point that we would look at includes the target population, the PIN, and the coverage. And this is used to calculate the number of services. For example, if we think about first-line treatment, you would treat the number of notified persons as your target population. We would expect all of them to need treatment, so we would have a population in need of 100%, and this would be multiplied by the actual intervention coverage, which could be used to represent the percent who are actually linked into care. The second example is patient support. We would typically start with the number who are on treatment and then look at a proportion of those who should actually get support, which might be those who are below the poverty line, or even in some cases, if all MDR are supposed to get patient support, then we could use that to represent the population in need. And again, coverage should represent actual coverage. You can enter a coverage number for all years, so you can vary that and scale it up over time. The target population can be drawn from time, the impact model, or user entered. Drop-down lists allow OneHealth tool users to select outputs from time to use as target populations for the costing calculations. The goal is consistency between the costing and impact assumptions. You can also adapt these target populations to your specifications. You can designate an age and sex that should be set as the target population, or you can select what we call user entered or direct entry, in which you would be able to put in an absolute number for each year as the target population. So there's a lot of flexibility to really craft a tool and a projection that represents the NSP or other strategic plan or policy shift that you want to be able to represent. The second point in that calculation, again, is the population in need, or what we call the PIN. The numerator in calculating the PIN is who should get the service from amongst the denominator of the target population. So again, I go back to my example of patient support, where we ask who should get this service. Is it all people on treatment, the percent below the poverty line, those with a low BMI, and then among whom? This might be a denominator of the population on treatment. In another example that I talked about earlier, if we're thinking about treatment, then we typically would use a population in need of 100% of the target population of those notified. You can see on the screen what the entry point looks like in the software. It's a series of cells that you can click into and edit if needed, similar to an Excel file. There are defaults that are provided, but they are user editable. And then the final point for the calculation of the total number of services is the coverage. This is typically user entered. We don't have a database of coverage for all countries. And so the user would be expected to go in and enter coverage for each year of the projection. That allows the calculation of the total number of services. Once the total number of services is established, we distribute those services by service delivery level or delivery channel, as we call them in the tool. The reason that this has been set up to allow a distribution by delivery channel is because there may be significant variation between service delivery norms or practices or the guidelines by level. And so the user can enter different costs for each level. By default, there are 4 costed channels named community, outreach, clinic, and hospital. These can be adjusted so as to best represent the delivery system in your country. There are other non-costed channels, including the private sector and other non-health, which is meant to capture costs that are not accruing to the public sector as something that's not included in this public approach, but still capture the health impact. Each delivery channel should sum to 100% for each intervention. So you can see in this image here, that first line TB treatment in this example is distributed 50% at community level and 50% at clinic. And then you have the opportunity to vary the costs by level. We're going to proceed now to look at the inputs for the OneHealth tool to calculate price, including drugs and supplies, personnel time, and inpatient days and outpatient visits. Calculating the prices for intervention costing includes each of those elements. If you move to intervention costing, you will see an average drug and supplies cost per case. And when you double click on the cell, it will take you to an editor where you can review and revise the default costs. There are tabs for drugs and supplies, medical personnel, and visits. As you can see in this screen, there are a number of defaults. These can be revised, and if you wish to copy them across to all channels, there is this button that's called Copy Treatment Inputs, and you can use that to copy any changes that you make to all channels if appropriate. Medical personnel time is the second tab. You can designate the % of clients treated by different staff types, the number of minutes that are spent in each visit, and the number of days or visits. Finally, the user can specify the number of outpatient visits or inpatient days for each intervention, and these will be used to calculate a cost if you've selected disease-specific costing. If you have not, they're still used to generate an estimate of the resource requirement, either bed days or outpatient visits. I'm going to move on now to the second element of the costs, which we call program costing or above service delivery costs. These are estimated using an activity-based costing approach, and there are a series of default cost categories, including program-specific human resources, such as the national TB program, training, supervision, monitoring and evaluation, infrastructure and equipment, transport, communication, media and outreach, advocacy, program management, and another catch-all category. These program costs are included in all different health areas. There are a series of TB-specific program costs and some adaptations that I'll talk about in our next session. The types of results that the user can get includes numbers of services, intervention costs and resource requirements, a summary of the program costs, estimates of provider time spent in training, which we call the training discussion, and then total costs, which summarizes the results for all the other components. There is also the opportunity to take advantage of what we call budget mapping in the tool, in which you have two primary goals. The first is to allocate the default cost categories of the OneHealth tool into user-specified cost categories. This can represent either the objectives that are represented in the NSP. It can include the Global Fund framework to facilitate preparation of a funding request, or any other series of cost categories that you might wish to represent. Once those costs have been allocated to the cost categories, you have the opportunity to map them to different funders. And this can be used to estimate the resource gap in order to understand where your NSP stands or your funding request stands in relation to the resources available. That describes the general costing approach. At this point, I'm going to mention two of the items that you need to decide when you configure your file and show you where those are found. And then I'm going to do a short software demonstration before wrapping up this session. The first decision that the user needs to make is to select sector-wide or disease-specific costing for labor and inpatient/outpatient care costs. This is found in the configuration editor, which I'll show you how to find in the software. And if you check a box for costing labor and visits by disease, then all the costs for labor or the provider time will be accruing under the TB program, and all the costs for outpatient visits and inpatient days will similarly accrue to the TB budget line item. If you do not check this box, the assumption is that you will cost those under the health system elements. The second item that you would want to select is the source for your impact estimates and your epidemiological projections. There are two options. The first is time impact, which is a dynamical model fitted to historical data. It's typically used to explore the implications of policy shifts. It requires mathematical model expertise or support from an expert in this area, but it does give you a longer-term projection and provides you with more information about the implications of changes in policy. The second is time estimates, which uses statistical projections to give you an estimate of the TB burden and requirements for different services. It's typically used for shorter time frames, can be used independently, and uses simplifying assumptions to estimate numbers requiring testing or treatment for TB. It does have a limited ability to reflect the impact of policy changes based on its structure. There are two other points that I want to mention that you have to delineate as you set up your file. The first is the base year, or the first year for the projection, and the second is the organization of the software. Once you've selected the first year, you cannot change it once you've selected that year and saved your file. And the reason this is because all the databases are organized around that first year, and so there's not an option to reconfigure and change it. The second is the organization of the interventions. One option is program areas, which is organized around vertical costing within HIV program, a TB program, and MCH programs, etc. And its alternative is a more horizontal or delivery channel package where interventions are organized according to the level of care. Typically for a TB program costing, we would recommend that you stick with program areas, as that will organize your interventions into something that's easily packaged for TB costing. And you're going to see as I set up a new file where these elements are entered. I'm going to proceed now with the software demonstration. Once you've opened the OneHealth tool, you have the opportunity to start a new projection. Once you've started the OneHealth tool, you have the opportunity to start a new projection. You can either select new projection here or start a new one up at the top. Starting a new projection will bring up the projection manager where you specify the name of the projection and the first and last year. I'm going to leave these as they stand by default, but I do want to remind the user that that first year is one of those items that you cannot change once you've made the selection. You can look at the OneHealth modules that are active, deselect those which are not relevant, and you can look at the impact modules and deselect those which are not relevant. I'm going to turn off non-communicable diseases for this example in order to keep the approach streamlined. The final item is to select default data for your country. For this example, I am going to use Ghana. You can see once you've made your selection of your country, that it will designate the different defaults and from which database they're being pulled in. When you select the option to move to the next screen, you'll be able to select either program areas or delivery channel packages. Just a reminder that program areas is typically recommended if you're just looking at one health area. And then finally, you can designate your method for calculating human resources. Unless you're working specifically with an HR plan, we recommend that you take the first option and calculate human resources based on target setting. When you hit the Finish button, the tool will start to configure your file and set up all the needed databases. You'll see a little spinning icon. You should wait until that spinning stops in order to proceed with your work. You can see the different components of the tool are being set in place. Once the projection has been set up, you'll be taken automatically to the configuration editor for the OneHealth tool. In the configuration editor, you have the opportunity to edit the program areas. So you can add or change program area names here. Remember, program areas are used as different buckets or groupings for the interventions which you use. Similarly, the subgroups are a different organizing tool for the interventions within the program areas. You can edit the delivery channels. So if you want to change the names or add different costed delivery channels, you can do so in this component. So that gives us our overall structure of the tool. The next area we suggest that you look at is the default interventions. So the button to select default interventions will bring you to a screen where you can designate what interventions are active. There's a search button, which I can recommend as you look for things because it's a long list. And if you deselect different items, if you uncheck the box, they won't show up in the costing menus. So it's an opportunity to just give yourself a cleaner look and feel for the tool if there are things that are not relevant for your program. The next item is Manage Custom Interventions. So if you wanted to add interventions that were not represented by default in the tool, you could create a new intervention. You could assign it to its appropriate program area and put it in the appropriate spot. So the subgroup will, again, put the information where you need it so that you can find it easily. So just an organizing function. Another organizing function, as you may imagine, is organize interventions. You can move items around. So for example, if you wanted to move the testing, the HIV testing of TB patients to the HIV program, you could select that intervention as something that you want to move, and then you could move to the HIV program. I'm going to use my search function. And move that to the HIV/AIDS program. So I check the box for where I want to move the intervention, and then you can see that it's moved the HIV testing and counseling for TB patients to this other spot. So again, this is just a way to organize the projection to mirror your program as closely as possible. You have the option to say that certain interventions cannot be delivered at different levels. So for example, if you wish to restrict the delivery of MDR to hospital level or clinic and hospital level, then you could uncheck the boxes under community and outreach for delivery channel availability. So for example, if you want to assume that XDR treatment and MDR treatment cannot be delivered at the community and outreach level, you would uncheck those boxes. You can see that that's going to take out the treatment input information for those levels, and it's fine to continue. The last organizational function I want to mention is intervention names. If there is an intervention that has a name that is not similar to what needs to be used for your work, you can select that intervention and give it a user-entered name in order to more closely parallel how you treat that intervention. The next item that I want to mention is the Projection Options tab. If you move to the Projection Options tab, you'll see that here is where you find our opportunity to make the selection to cost, labor, and visits by disease. Remember, if you check that box, it'll accrue the HR and inpatient day and outpatient visit costs under each different health area. You also have the opportunity here to make your selection around the TB impact model. So if you are using time impact, you would check the box to use target populations and populations in need from time impact. If you're using estimates, you don't need to make any selection here. The final configuration item I want to mention is the Currency and Inflation tab. You can specify which currency you wish to enter costs in. If you check this box to enter costs in US dollars instead of local currency, all the information you see presented will be in US dollars. In either case, you should review and revise the exchange rate, and that will allow you to appropriately toggle back and forth in your results between currency. You can also specify the inflation rate, and inflation can be applied at the results editor level. Once those selections have been made, you can proceed to program or channel analysis and select the TB program area for your work. Within all the different health areas, you see a similar series of menus, including intervention costing, program costing, and results, which are going to be the focus of our work today. Under intervention costing, you can see that we've got different menus that represent each of the different components of our cost calculation: target population, population in need, and intervention coverage in order to calculate the number of services, delivery channels to distribute them by level of care, and treatment inputs in order to represent the different resource requirements. And if you've selected the disease-specific costing option, there'll be an entry point for outpatient and inpatient costs. Let's start by taking a look at the target population editor. When you make that selection, the tool will start to do the calculations of the different target populations. This can take a moment, particularly the first time you do this activity, because it will be running information in the background. Once you've selected the target population editor, you will see a list of the different interventions and the selected target population. You can use the drop-down menu to make your selections. If appropriate, you can make changes, including, for example, setting the different populations like direct entry, in which you would identify a number of persons who might need direct entry, in this case, intensified case finding. Or you can also select what we call a custom target population, in which you can select the sex and the starting and ending age of the population of interest. Once you've reviewed and revised the target population as needed, you can move to the population in need. The population in need has a series of defaults, which represent the proportion of the total population, which should be reached with the services. One interesting point about the TB models is that if you are using estimates, we use the target for diagnosis to be numbers of notified cases, and we use the population in need to represent the number needing to test. So for example, if we think about microscopy, the number needing to test here is represented as 20 people for every notified case. Coverage is the next item that we need to calculate the numbers of services. And you can either look at the first and last year, in which case there would be a linear interpolation between those, or you can check the box to show all years of scale up. And then you can do an entry point for each. So for items like treatment, you would typically put in coverage of treatment. If you are, for example, linking 89% now of all your notified cases into care, but you hope to see that go up to 95% by the last year of this work, then you could put in those first and last year targets, and you could either key punch their interim years or take advantage of interpolation, which will calculate for you either a linear increase, an S-shaped increase in which the pace of increase is steepest in the middle years, an exponential increase, which increases the most at the end, or a front-loaded increase. So once you've made all these entries, this will calculate the total number of services. You'll recall that we want to calculate each delivery level's numbers of services as well. And in order to do that, we need to understand the distribution by level. We have a series of default entries that have been developed in collaboration with subject matter experts in order to provide a global picture, but we recommend that each country review these and revise as needed. You'll want to make any changes in both the baseline and the target year. You may remember that I entered a custom intervention, which is the new custom TB intervention that you see here, and that defaults to 100% clinic level. So I would particularly want to review and revise any custom interventions that I add, as there will not have been any information for the computer to have distributed them logically. Once you've reviewed and revised the delivery channels, you now have all the information for the tool to calculate the number of services, and you can move on to treatment inputs. Once you select treatment inputs, you can double-click on any cell, and it will bring you to the detailed costing elements for that item. So this is the costing for diagnosis with microscopy. You can see that it's being estimated in local currency here. If I want to view the information in dollars, I would return to configuration and make this selection under currency and inflation to enter costs in USD. Once I've done that, you can see it's approximately 31 cents estimated for a microscopy test. And you can see all the different costs for different levels of testing, for screening, first line, second line treatment, etc. All of these can be reviewed and revised as needed by the user. So if we wanted to revise the costs for a previously treated regimen, there are a number of the different drugs that are built in with the associated unit costs. So you can either take the opportunity to change the distribution of clients across the different regimens, in which case the costs would be estimated based on the clients that you've now said are going to take 4RH and 2RHCE. If you need to change the unit cost, you can double click on the unit cost cell and make the change by clicking in. I do recommend that everyone make sure to change the cost for all years, and if you make these changes. If you just want to change the costs at one level, you can do that. Or if you want to copy them across to all levels, you can use the copy treatment inputs component or option. The second tab is medical personnel. This estimates how much provider time is needed to deliver the services and lets you distribute across different provider types. If you need to add additional medical personnel to the list, to the defaults, you can click the Add button and a list of provider types comes up. You would want to designate what % they're treated by, how many minutes are spent with them, and how many times they are visiting with this provider. The last tab is about outpatient visits and inpatient days, and you can put an entry in for either. So for example, if we think 2% of previously treated clients are going to need a 5-day inpatient stay, you could make that addition. All of these elements will be used to calculate the total costs of the care. So again, under results, you've got the total number of services, which are being driven by the target populations, populations in need and coverage. And then you've got the intervention costs, which include consumables, labor costs, outpatient and inpatient costs, if you have taken the disease-specific option. The next element that we want to review is program costing. This is meant to represent the above service delivery costs and includes things like program-specific human resources, training, supervision, M&E, etc. By clicking on each row with a decimal designation, you can enter information. So for example, if you look at the national level staff, you can enter a salary and a number of staff required in order to get an estimate of the costs for those personnel as part of your program costs. Each of these different decimal designated rows has a series of costing templates built within it, which you can fill out to estimate the costs of your plan. These will be rolled up into the whole number rows in order to give you a cost for each of the buckets of program costs. We also have a number of TB-specific program costs, including collaborative activities, active case finding, infection control, childhood TB, IPPM, ISTC, community involvement, partnership initiatives, TB prevention, and research. Anything that hasn't been previously contemplated as part of the defaults can be added by double-clicking and adding your custom type. Once all of these pieces of information have been filled out, you can generate results, including the number of services. This will not be something that makes sense in this file because I have not yet entered sufficient information, but this is where you can find the results for numbers of services. You'll notice that there's a calculation that happens in the background, and then it brings up the result for you to edit and specify whether you want to see it in a graph or a table. And for cost results, whether you want to add inflation and which currency you want to see. The first time you run a calculation, it will typically take a little bit longer because it is doing some background runs. So in the editor for numbers of services, I usually like to do table. You can also do bar charts for a visual representation, and then you'll get results for numbers of services. As you can see, I didn't put in sufficient information, so these are 0 in this particular case. You can also look at the cost per service, which is the unit cost, and then the intervention cost, which would be the unit cost times the numbers of services. You can also get a program costing summary, and you can, in all your cost outputs, go back and forth between the currency, and you can add inflation if needed. The final item I'm going to mention is the budget mapping approach, where you can take the cost categories from the OneHealth tool and map them to the different cost categories that you might select. And this is going to be covered in further detail in session 3, special features. The last point of the day is to say that there is an online survey. We are very much interested in your feedback. You can see Inez and my smiling faces waiting to hear from you. We hope that you'll reach out if you have any questions or comments, and we hope that this session has been useful for you.